So let's talk about the 5 categories of medications that LPNs cannot give. Let's start at the top here with hyperailments. Then we go down to antidysrhythmics, oxytocics, antineoplastics, and blood. So let's touch base on some of this. So let's start with antidysrhythmics. Antidysrhythmics, the main one that we're going to talk about is amio or amiodarone, which took me forever to learn how to say correctly. LPNs aren't going to be working with antidysrhythmics, at least not IV. You guys have probably seen amiodarone given orally, and that's fine for people that have AFib. But our antidysrhythmics are not going to be used because that is an unstable patient. And as a class, as of LPNs, you can't take care of unstable patients, right? When patients become unstable, it's time to recognize, ship them out. That is kind of the LPN's role. So antidysrhythmics are typically going to be your unstable patients. They're going to be on a progressive care unit or an ICU. So not one we're going to see a whole lot. Then we go down to oxytocics, I don't know. I've never given this medication ever. It's known as Pitocin. So Pitocin. This is not a medication you're going to give because these are birthing moms. This medication is for getting babies out. And so that's something that unless you're working labor and delivery, you're not going to see. Sometimes you might give it for somebody who's having some sort of uterine hemorrhage. We might give oxytocin to clamp them down. But again, not something we're going to see. That is not a stable patient. So not somebody, not something an LPN is going to see. I've never seen this medication either. Then we work our way down to the bottom, and this is antineoplastics. These are chemotherapy agents, and our chemotherapy agents are going to be things like our adriamycin, which is a medication that we give for chemo to get rid of the bad cells. You've got Cytoxan, methotrexate, all right. These are going to be given by a special nurse, RN, that is trained in giving these kinds of medications. They need special training because we can't get them on our skin, we can't touch them, all that kind of stuff. There's a lot more safety features that go to giving these medications, not to mention then we have to be able to monitor patients appropriately. That doesn't mean that you aren't going to see patients that have been given antineoplastics and are coming back to the facility or coming to your clinic. So you still need to know how to take care of patients that have had chemotherapy meds. One, we know their white count is going to go down. So we're going to be wanting to wash our hands and take care of infection risks. Very, very important as we're working with these patients. Another thing is that they may lose their hair or they may have nausea and vomiting. So we may be giving them a little bit more Zofran or Phenergan or something to help them work through the side effects of these medications. So although you won't see or you won't be working with these medications, you'll be working with some of the after effects of these medications. So it's important when you're working with somebody who's taking them, even though you're not giving them, if they're coming back to you, you do some research and you dig into those medications so that you understand what they're going to do. Not all meds make you lose your hair. Not all meds make you nauseated and vomit. But a combination of them can, and different patients react to medications differently. Let's jump up to our hyperailments. This is TPN, total parental nutrition, meaning we're giving all of your nutrition and your nutrients in through your IV. Now, we've talked about hypertonic solutions, and this would be a hypertonic solution. We're giving a very concentrated fluid in your vessels. So think about where this solution needs to go. This will always be in a central line. Every time, always. We do not put TPN through a peripheral line because it will burn too much. It could be a PICC line, it can be some sort of port or Grishong, lots of different types of central lines, but TPN is always given in a central line. We do see TPN given on a med-surg floor. We see people at home with TPN. So it's just for whatever reason, somebody needs a little extra nutrients. Either they've had gastric cancers and have had so much of their bowel or stomach taken away that they can't absorb stuff. Like I've told you guys before, I have a friend who was hyperemesis as a pregnant mom, and she had to have TPN. So we see things like this being out amongst the crowds, and we see them in our facilities, and we see them on med-surg floors. So, what do we as nurses need to know about this stuff? One, it's given in a central line, so we have to really pay attention to that access site, be assessing it well, making sure it still looks good. Other things that we need to make sure that we're doing is we're probably going to be checking their blood sugars at least Q6 hours when they're on the floor at a med-surg floor. TPN has a lot of dextrose and sugar content, so it can shoot those blood sugars way up. Really important for us to take care and watch. We're also going to be watching their other lab values because all of these nutrients, they have potassium and sodium and mag and phos and all sorts of stuff in them. So we really got to be watching those lab values to make sure that they're getting the proper amount. Our last one on our list is blood. And while you cannot give, as an LPN, cannot give blood, you can be the second nurse on the double check that comes with blood and any blood product. So there's lots of different blood products. You have packed red cells. You have plasma. Oops, plasma helps if I can spell right. You have platelets. You'll hear cryoprecipitate. Albumin is a blood in the blood. It's an actual protein that's in there. So there's a lot of different things out there. Things that we're going to have to watch as a nurse. We're going to have to watch for signs and symptoms of reactions. So you're going to take a round of vital signs before you start the blood or blood products, and then you're going to take it about 15 minutes later, you're going to take another set of vital signs. If we see any dramatic changes in those vital signs, we need to stop the blood. That means there's some sort of what they call a transfusion reaction. If you don't see that, then we're going to be looking for things like backaches. If somebody all of a sudden has a backache in the lower part of their back and they're rubbing it and they're like, holy cow, I don't know what's going on. My back hurts. Your kidneys are back there and your kidneys filter blood. So really we can see that happen where all of a sudden their urine turns dark colors, their back hurts. That's a sign of a transfusion reaction. A rash is a sign of a transfusion reaction. All of a sudden, any type of thing where they're sweaty, diaphoretic, sudden changes usually let us know that there's some sort of transfusion reaction. When we're talking about vital signs, an elevated temp is one of the first signs as well. What do we need to do about this? We need to stop whatever is infusing, and we need to get the RN and probably initiate our policy and procedure on a transfusion reaction. A lot of times we have to clamp off the blood and take it down there. We have to get samples. I mean, it's just a big process of what we have to do. So these are the 5 categories that we need to be careful with when we're giving medications. That LPNs don't give hyperailments, which is TPN, antidysrhythmics, which is typically amiodarone, oxytoxics, which is your Pitocin, your antineoplastics, so your chemotherapy agents, adriamycin, Cytoxan, methotrexate. There's a bunch more out there. And your blood products, your packed red cells, plasma, platelets, albumin, all that kind of stuff. So I hope this helps you guys kind of understand what things you can and can't give, and I look forward to learning together.